Am I audible, Shri Priya?
Yes, ma'am. Perfect.
So good evening. Thank you so much. And it's a pleasure to take this class. Although it is a little difficult topic, it is not difficult pain. Okay? And try to make it as simple as possible, although it is a difficult pain. And can I just start the screen sharing?
Sure, ma'am. Yes, ma'am. We are good to go. Ma'am, you're not audible.
Now can we proceed?
Yes, perfect. Good to go.
Okay. So I will be talking on approach to a patient with difficult pain. Now, we all know that WHO analgesic ladder, which we went through last time, in which it's a 3-step ladder, in which for the most severe pain, we can use strong opioids with or without an adjuvant. Okay. But I mentioned to you that despite that, only 71 to 76% of patients can have good pain relief using this ladder. So the remaining may not respond to the may or may not respond to the strong opioids as well. And that is a category in which I want to talk about today. And it is called refractory cancer pain or intractable cancer pain. So there are a lot of terminologies for this difficult cancer pain. It can be called intractable, it can be called persistent, it can even be called opioid non-responsive pain. So what's the definition of a difficult pain? It is pain related to cancer or its treatment of at least 3 months duration that has not responded to standard treatment with opioids and co-analgesics. I mentioned about co-analgesics, about adjuvant drugs. So despite that, so that is the definition of difficult cancer. Now, there are certain risk factors which predispose a patient to intractable cancer. Young age, they may be more unresponsive. Neuropathic pain can be sometimes very difficult to feel. Then when there's incident pain, pain can be both continuous and incident. Okay, continuous is what is there, baseline throughout the day. And incident is what happens when there's a sudden peak due to any activity or there's a very sudden spurt of pain. So that can be difficult to treat. Then there's associated psychological distress. When there's previous opioid use, which may make them unresponsive or opioid tolerant. If there's a history of addiction, these people also can be quite unresponsive to opioids. And also when there's impaired cognition and the patient is not able to understand or, even maybe it's possible that they are not understanding the way to take the medicines and things like that. So that is also one of the predisposing causes for difficult cancer. Now, before I start, I want to present a case scenario which I encountered last year and which was a case of difficult pain. So this was a 62-year-old man with CA rectum with peritoneal and liver metastasis. He was on chemotherapy since last 1 year. Initially, he responded, but after 1.5 years of chemo, he suddenly developed acute intestinal obstruction with pain in the abdomen due to progression of the primary lesion. So he was taken to the emergency room and admitted for conservative management of intestinal obstruction. A Rice tube was inserted and colostomy was done. And he was discharged with the advice of continuing with palliative care. Because at that point of time, they felt that chemotherapy may not be that effective. Initially, he was taking and responding to WHO step 1 and 2, which was given through the nasogastric tube along with adjuvants for pain management, for the pain abdomen. But the abdominal pain persisted. And then he had to be stepped up to step 3 drugs orally. We were giving him morphine. But one day he pulled out the Rice tube and he did not want it to be reinserted. Now he had by the time become very frail, and to reinsert the tube was not a big job. We could have easily restrained him and inserted it. But we had a family discussion with the wife and the children as to how to feed him, and as he had become extremely emaciated and weak, and whether we should put in the reinsert the rice tube or not. But because the patient was very, very categoric that he did not want a rice tube, we respected the patient wishes, and we that's called patient autonomy, and we decided not to put in the rice tube against his wishes. So he was started on IV fluids through his chemo port that he already had. So we were giving him only maintenance IV fluids. The pain grew worse, and he had to be started on a transdermal fentanyl patch because of this no rice tube. We could not give him morphine, so we was put on transdermal fentanyl patch, 25 mics per hour, along with oral transmucosal fentanyl citrate, that is OTFC, that is a fentanyl lollipops, which is about 200 mics per lollipop. That was given SOS for the incident. Now, despite that, there was no relief, and he remained in agonizing pain, and he, in fact, was shouting with pain. The family became extremely distressed. So, what do we do next? So, this is a scenario in which the pain had become intractable, and we were in a dilemma as to how to handle this problem now, because we knew that he did not have much time to live, but the family wanted him to be as comfortable and pain-free as possible, and they could not bear to see him crying in pain. So when you look at this, when we come across such a situation, the first thing we need to do is review the whole case. And then we need to manage based on either pharmacological or non-pharmacological options. The pharmacological options include conversion of the route of administration of the analgesic, or rotate the route, or maybe add new adjuvants. And non-pharmacological treatment would include interventional pain management, psychological therapies, physical therapy, alternate therapy, spiritual therapy, which can be given in a multimodal way. Now, let's review the case. For this, we need to remember the ABCs. A is the patient adhering to the treatment, first of all. B is we have to believe that the patient has pain. If he's crying in pain, it means he has the pain, because it was Margot Metaphori in 1968 who said that pain is whatever the experiencing patient says is existing whenever he or she does. In simple terms, pain is what the patient says. So we have to believe the patient. The C is we may need to do a comprehensive pain assessment again. Go through the pain characteristics, go through the functional history, how much is the patient able to function, review the prior drug and non-drug history, examine the patient and review. And another C is we need to correct the correctable factors. These may include tapping of a pleural effusion, or maybe it is a ascitic fluid that has to be tapped, or whether there's an underlying superadded infection. Is there insomnia? Is there anxiety? What about the nutritional status? So all these correctable factors need to be also dealt. Now, adherence to treatment. When we review the analgesics, we should review the adjuvants. We should see whether the patient is understanding the doses that are being given at what time. So if the prescription reads paracetamol 500 mg 3 times a day and morphine 10 mg every 4 hours plus SOS doses and all the rest of it, we have to make sure that they are following it like we have described. Because sometimes they may think it's not important to give according to the duration of action. They may wait for the pain to come back to treatment. So we have to first see that they're adhering to the treatment. And for this, we can use teach-back techniques. We can ask the patient, you tell us how you're taking it, and ask them to explain everything to us. So that way we'll know whether they are adhering to the treatment like we have wanted. So what are some of the causes for opioid ineffectiveness? Why are the strong opioids even not active? The most common reasons are whether the reason is the toxic metabolites getting accumulated. We all know that morphine is metabolized to morphine 6 glucuronide and morphine 3 glucuronide. So Some of these are toxic metabolites, and their accumulation can also lead to refractory. Another very important thing is the progression of the disease. That's a very common reason why now the pain has become unresponsive. Or is there a new pain type? Is there a neuropathic element? Is there a bowel obstruction? Or is there spasticity, etc.? So we have to, by reviewing the case, we will come to know, and doing a comprehensive pain assessment, we'll come to know whether there's any new pain type. Then are there intolerable side effects like neurotoxicity, which can manifest as sedation, delirium, hyperalgesia, or myoclonus? Or has that particular route of administration failed? And that could be, there could be poor oral absorption or diminished transdermal skin absorption. That could be another reason why the opioids are not working. Or if the patient is having a continuous nerve block or a continuous epidural, is there a failure of the pump? Or, in other words, is there a malfunction of the catheter, blocked catheter, needle, or pump? So we all know that they can be given intravenously, subcutaneously, or even intrathecally or epidurally. So we should know whether there is a failure of the route of administration. And very important, we have to look into the psychological, social, and spiritual factors. So that could be another reason why the patient is becoming so restless. So when you look at the management of difficult pain, we look at the pharmacological and non-pharmacological options. Now, in the pharmacological options, the two important things we can do is opioid manipulation, which means we can convert the route from either oral to parenteral, or maybe from oral to transdermal. Or the second way of manipulating the opioid is by rotating the opioid, which is called an opioid switch. The other thing that we can do pharmacologically are, we may have to add adjuvants. Now, I had talked about adjuvants in my last presentation. So I will not focus too much on antidepressants and anticonvulsants because we had done that in detail. But the other adjuvants that may need to be added in patients with intractable pain are NMDA antagonists, antispasmodics, local anesthetics, corticosteroids, and now there is a lot of information on cannabinoids also in the treatment of this. So let us discuss the opioid manipulation. We know that IV opioids, if oral is not working, we can give it either subcutaneously or intravenously. This can be given as a continuous infusion for continuous pain, or as an intermittent bolus for the incident or the breakthrough pain. Now, many of us could be familiar with patient control. Continuous and incident pain, because there's both a continuous infusion or a basal infusion, and if the patient has an incident pain, then they can give a bolus dose themselves. Okay, so these are available as disposable elastomeric pump, which is shown over here, in which you have a remote over here, and by pressing that you can give a bolus dose. Or you can give what is called a CADD pump, or the continuous ambulatory drug delivery pump. In this, you have to load the drug, and there is also a remote in this, and this can also be given as a continuous infusion and a bolus dose for the breakthrough. So these are the ways in which we can give intravenous, or even for that matter, subcutaneous smoke. Now, in route conversion, we can give, like I said, it's the same opioid that we are giving, but only we are changing the route of administration. For example, we are converting oral morphine into IV or subcutaneous, or transdermal fentanyl, we are converting into intravenous fentanyl. The high serum concentrations can be achieved by both the IV as well as the subcutaneous route. And both morphine and fentanyl can be given through both these routes. The conversion factor we should remember from oral to subcutaneous to intravenous is 3:2:1. That means if the patient is taking 30 mg morphine, then the subcutaneous dose would be 20 and the intravenous route would be 10. Now, there is no evidence of the superiority of parenteral versus oral opioids to control cancer. And the European Association of Palliative Care recommends the use of parenteral opioid infusions in cases where the oral or the transdermal opioids fail to provide effective analgesic. Now, the next way of manipulating the drug that we are giving is opioid rotation or an opioid switch. Now, in this, we are using the same opioid, whether it is morphine or whether it is fentanyl, but we are only changing the route. So, we are using different opioids, but in the same route. I'm sorry. For example, we convert oral morphine to oral methadone. The route is the same, but the drug is different. So what are the indications for opioid rotation? First of all, when there is intolerable side effects of morphine, like neurotoxicity, which I talked about earlier, or if there is poor analgesia despite the titration. How does it work? How does opioid rotation work? That is because there is a tendency for incomplete cross tolerance among opioids. So when you change the route, the analgesic efficacy could be better. Not change the route, change the drug, then the analgesic efficacy could be better because there are some opioid receptors which are still responding to the opioids. So you have greater than anticipated potency with another opioid. So how do we do an opioid rotation? There are basically 3 steps. First of all, we have to look up the equianalgesic table to find out what is the equianalgesic dose of that particular opioid. For example, if you're giving 60 milligrams morphine and you want to convert it to fentanyl, then it is equivalent to 25 mics of fentanyl per hour. So once you calculate the equianalgesic dose, then you have to account for the cross tolerance amongst the opioids. If it is a well-controlled pain, then you have to reduce that equianalgesic dose by 50%. But if it is poorly controlled pain, then you only reduce it by 25%. The only exception to reducing this, that where we do not reduce, is methadone. That I talk about later when I'm talking about methadone. And also don't forget to prescribe a rescue dose as well once you have done the opioid switch. I mentioned about opioid-induced neurotoxicity, and the cause of that is because of the accumulation of metabolites like morphine, 3-glucuronide, and norepinephrine. And they're manifesting as the sedation, delirium, hallucinations, myoclonus, hyperalgesia, seizures. So when that is happening, then you know that the patient is going into neurotoxicity, and we need to either bring down the dose or we need to change the dose. Now, the opioid switch in our country, we can only do using methadone and fentanyl other than morphine, because what is available in the West is not available, like oxycodone and certain drugs which are not available here. So methadone is inexpensive and it can be given orally, but remember that is under the same legal control as morphine. So we need to be as careful as morphine when we are prescribing it. What are the advantages of methadone for difficult pain? First of all, it has a high potency. And the second is, it is very effective for neuropathic pain because it can block the NMDA receptors, and also it acts at the serotonin norepinephrine reuptake unit. So that's why it is effective for the neuropathic pain. Secondly, another reason is it has no known active metabolites like morphine. It has a long half-life, so there is less risk of breakthrough pain. Its half-life is 8 to 12 hours. Yet it does not accumulate in renal impairment. There is less tendency for tolerance and there is no cross tolerance. So that is why we do not reduce the dose of methadone when we are converting from morphine to methadone. And also it is relatively inexpensive, but it has got disadvantages. The first is the cardiac problem that can happen with methadone, and that is a risk of life-threatening ventricular arrhythmia, particularly if the QTC prolongation is there on the ECG. That is called torsades de pointes. Now, titration is also difficult with methadone, and so there could be a risk of overdose because the half-life of methadone is very low. And also, it has to be given only by experienced palliative care specialists, those who are experienced in giving the other drugs of the NDT. So what are the indications of methadone? The first is when you want to use it as an opioid rotation or opioid switch. Secondly, it is not, it's the least expensive of the long or active opioid drugs. When there is true morphine allergy, you may have no option but to give that. And also in the treatment of neuropathic pain. But the contraindications is when there's prolonged QTC more than 500 milliseconds, when there's no reliable caregiver, when there's a history of sudden unexplained death in the family, and when the patient is on some drugs like azithromycin, fluconazole, and amitriptyline. These are some of the contraindications why you don't give them. So converting morphine to methadone, this is how you do it. If the patient is less than 60 mg morphine per day, then the methadone dose is 2 to 7.5 mg. If the patient is getting between 60 to 199 oral morphine equivalents and less than 65 years of age, the conversion is 10:1. That means if you're giving 10 mg morphine, then you give 1 mg oral methadone. And if the patient is on more than 200 mg oral morphine equivalents, then or more than 65 years of age, the conversion is 20:1. That is, the patient is getting 20 mg morphine, you give 1 mg oral. It is available as 5 mg tablets and syrup at 5 mg per ml. And as per expert consensus white paper, the equianalgesic doses suggested for methadone are very conservative, and we need not account for incomplete cross-talks. And that is why we do not reduce the dose after calculating the equivalent. Now, another strong opioid that we can give is transdermal buprenorphine. This is another option for opioid rotation. It can cause good pain relief. It has good tolerability. It can control neuropathic pain and breakthrough pain as well because of its long half-life. And it's available as Buvelor patches, either 2.5 mics per hour or 5 mics per hour. And the effect usually lasts for 7 days. So every 7 days, you have to change the transdermal patch. Now, having gone through the various drug causes, now we have to also see whether the patient is having, is it only nociceptive or is it a neuropathic pain or is it a mixed pain? And is there a need for adjuvant drugs? Now, I had already mentioned in my previous talk about where the nociceptive pain occurs, because that occurs, it is happening at the level of the nociceptor. But anything beyond the nociceptor, that is the peripheral neuron, the dorsal and the spinal cord and the brain, comes under neuropathic pain. When there's a lesion anywhere beyond the nociceptor, it is neuropathic pain. And of course, there is mixed nociceptive and neuropathic pain as well. Like I mentioned, I won't be talking about the anticonvulsants and antidepressants because I've gone through in detail. So I will focus on some of the drugs that we're giving for very difficult cancer. So ketamine, I said, blocks the NMDA receptor both in the spinal cord as well as in the thalamus, and that is how it exerts its pain. So they are can be given when neuropathic pain is unresponsive to the antidepressants and anticonvulsants. It can be given through a variety of routes: intravenous, intramuscular, subcutaneous, oral, sublingually, intranasal, rectal, topical, intraarticular, epidural, intrathecal. Lot of routes you can give ketamine. And oral bioavailability is relatively poor. It's only 20% after 30 minutes, and it lasts only for 3 hours. But the intramuscular route, you have a high bioavailability. 90% is available within 5 minutes. Now, we know about this dose of ketamine. It's given in sub-anesthetic doses. And in oral ketamine, you can go up to 10 to 25 mg TDS. Subcutaneous, you can go from 50 to 100 milligrams per day, with a maximum of 20. But for intractable pain, we use what is called a burst ketamine or a pulse course of ketamine. That is given for a maximum of 5 days using a syringe pump after the patient is admitted with continuous monitoring. So you start off with 100 mg in 24 hours through a syringe pump for 3 days. If it is not effective, you can step it up to 300 mg in 24 hours, continue for another 3 days. If that is not effective, you can go up to 500 mg in 24 hours, and then after that, we'll have to stop. So that is how you give burst ketamine, which may be effective in intractable pain, particularly neuropathy. We all know the side effects of ketamine, so I won't go through it. I've dealt with it last time. The other thing that we can use for difficult neuropathic pain is local anesthetics. Okay? And this is reserved as a second line treatment for severe intractable crescendo kind of neuropathy. It can be given as an intravenous local anesthetic infusion. You calculate the dose as 5 milligram per kg, add it in 500 ml of normal saline, and administer it for 1 hour. This is, like I said, can be given for the intractable neuropathic pain, but at the same time, we have to do it after the patient is admitted with cardiac. Topical local anesthetic patches are also available. 5% lidocaine patches are available in India. So if you look at the neuropathic ladder, the first line treatment for neuropathic pain is amitriptyline and anticonvulsants like pregabalin and gabapentin, duloxetine, and lidocaine patch. Second line treatment, you can give opioids and tramadol. And the third line, you can use drugs like baclofen, mexiletine, capsaicin, 0.75% patch, and ketamine. Now, a word about cannabinoids in difficult cancer. We know that cannabinoids have been used for various ailments since ancient times. But in medicine, the use is restricted because of legal and social concerns due to drug misuse and abuse. But there are few symptoms that can occur in cancer patients that can be resistant to the current palliative care treatment options. And in such patients, you can use cannabinoids. Although there is absence of robust clinical data, whether it has a favorable risk-benefit ratio, it is still can be tried, but it is yet not routinely included in the palliative care. Now we know that endocannabinoids act on the CB1 and CB2 receptors in the central nervous system. Now CB1 receptors accounts for the well-known psychotomimetic effects of cannabinoids, like the high that they get or the hallucinations that they get. And the two phytocannabinoids that have been extensively studied are THC, which is tetrahydrocannabinol, and CBD, which is cannabidiol. Nabiximol or Sativex is an oromucosal spray which contains a 1:1 combination of THC and CBD. THC is a principal psychoactive constituent of cannabis plant, and CBD is the anti-inflammatory property. This has shown to be well tolerated and can provide improved analgesia in opioid unresponsive cancer. Now, cannabinoids have also been used for chemotherapy-induced nausea and vomiting, and the ones that are used are dronabinol and nabilone. Now, droneobilone is a naturally occurring cannabinoid, and it can be synthesized chemically or extracted from the marijuana plant, Cannabis sativa. It stimulates a CB1 subtype of the cannabinoid receptors in the chemoreceptor trigger zone and the emetic center. And this is how you give it. And the principal active ingredient of this is THC. It is useful when other antiemetics are not effective. It can also stimulate the appetite in cancer and AIDS patients. Now, nabilone is a synthetic cannabinoid with an action similar to dronabinol, and this also is absorbed after oral administration, and it can be given as a prophylactic in chemotherapy-induced nausea vomiting when other antiemetic drugs are not. But there are some side effects of cannabinoids that we should keep in mind, and that is, the first is the neuropsychiatric ones. It can aggravate pre-existing anxiety, schizophrenia, or depression. It can cause impaired cognition with excessive sedation and impaired motor skills. There is a risk of infection as it can reduce the host response. And the cardiovascular effects include hypertension, hypotension, tachycardia. So we should avoid it in patients with heart disease. So what are the uses of cannabinoids in palliative care? It is useful in neuropathic pain as a third or the fourth line treatment and not as a first line. It can be given, like I mentioned, oromucosal nabiximol or an inhaled herbal cannabis or nabilone and pronabol. It can also be used for chemotherapy-induced nausea vomiting. It can be used for cancer anorexia, for HIV-related cachexia, for multiple sclerosis-associated spasticity, and also the neuropsychiatric effects help in improving the general well-being and quality of life in patients with these chronic debilitating illnesses. What is this use of, is the use of cannabinoids legal in India? What is the current status? Now, in the West, it has been approved for the treatment of neuropathic pain, especially due to multiple sclerosis and refractory pain and cancer. But in India, there is a little bit of haziness about this. So recently, there was a petition in the Delhi High Court which challenged the provisions of NDPS Act and said that it should be legalized for medicinal purposes. The center has now informed the court only this year that cannabinoids can be used for medicinal and scientific purposes and that it is not completely banned. So that we can keep in mind when if we have to prescribe cannabinoids. Now, corticosteroids is also a very useful multi-purpose adjuvant that can be used in refractory cancer pain, particularly those related to neuropathic pain, bone pain, headaches because of raised intracranial pressure, as it reduces the peritumoral edema, and also bowel obstruction and spinal metastasis. The first line drug is dexamethasone. Because of its long half-life, it needs to be given only once a day. It's the most potent anti-inflammatory effect as compared to the other steroids. And it also has less mineralocorticoid effect, so less retention of water and sodium. And it can provide short-term relief of pain, particularly beneficial for those with less life expectancy. Now, GABA receptor agonists are other drugs that can be used as a third-line treatment for difficult. Basically, it potentiates the inhibitory effects of the presynaptic GABA, which is an inhibitory neurotransmitter. So there are two types of GABA receptors. One is a GABA A receptor agonist, and these include benzodiazepines, but of that, only clonazepine has been used for neuropathic pain. And GABA B receptor agonist is baclofen. That also can be used for spasticity association with pain. So if you want to give clonazepam in palliative care, for neuropathic pain, the dose is 0.5 mg, which can be given orally, or if you want to give in divided doses, you can go up to 8 mg. And for terminal sedation, you can give again 0.5 mg orally, which can go up to 2 to 8 for 24 hours as a subcutaneous infusion. Now, baclofen is another drug, which is a GABA agonist. It blocks a GABA B receptor, and this can be used for various conditions associated with pain, particularly refractory pain like spasticity, neuropathic pain. It can be used for hiccups and musculoskeletal spasms. So this I've talked about earlier, so I won't talk about it now, but it can be given orally as a topical cream or even as an intrathecal pump. For bone pain, that's another cause of very refractory cancer pain because of the skeletal-related events. And this can really affect the quality of life of the patients. So the various drugs options that we have are corticosteroids and NSAIDs, calcitonin, but again, the recent review shows that it does not cause significant improvement in quality of life. But you can try bisphosphonates, denosumab, and also palliative radiation. This again I've spoken about in my last presentation, so I won't go through this. This also I've spoken. Pain due to bowel obstruction, very important, particularly when you talk about this patient that we have just discussed. And steroids can help reduce the edema. You can combine it with the anticholinergic agents like hyoscine butyl bromide, glycopyrrolate, and somatostatin analogs like octreotide. So we have now talked about the pharmacological options. So what are the non-pharmacological? So that, if you look at, is the step 4 drugs options. They include nerve blocks, which can be continuous nerve blocks or even a single nerve block. It can be epidurals, which can be given again as a patient-controlled analgesia, or patient-controlled analgesia pump can be used, or we can give a neurolytic block like a celiac plexus block using alcohol or phenol, or you can use spinal cord stimulators and also intrathecal pumps. So these are the advanced interventions that can be used for cancer pain that are not responding to the step 3 drugs. There are non-pharmacological treatment options as well, which include dry needling, acupuncture, biofeedback, psychological therapy, physical modalities, spiritual therapies, and alternate therapies. So the physical therapy that we use in palliative care include ambulation and musculoskeletal therapy, neurological therapy, electrophysical agents, mechanical therapy, and education. Education is very important, and modalities that we use are heat, cold, TENS, and teaching the activities of daily living and exercise to maintain the functional range of motion. Now, cancer patients can have a lot of psychosocial and spiritual issues as well. They include fear and anxiety, depression, anger, guilt, financial issues, fear of the future, concern about loved ones, loss of role or role reversal, and questioning God. So the various therapies that can be given include counseling, communication, medications, forming support groups like art therapy, music therapy, dance therapy, and financial support for the family and children's education. Now let us look back at the case scenario that I discussed in the beginning. Now he was having refractory cancer pain, and which was not responding to step 3 drugs. So what were the possible causes? Like when you review the cases, we have to look at the medical reasons. Is there a progression of disease? Well, the colostomy site definitely looked unhealthy when he was taken to the ER. Secondly, is there a failed route of absorption? He was not orally absorbing the opioids, and also the fentanyl patch also was not very effective. So is there a failed route of absorption? And the other thing we need to see is, are there psychosocial concerns? Now, this gentleman was readmitted to the hospital. The colostomy was found to be non-functional, so obviously that was a cause for severe pain. And then an opioid route conversion was done. So instead of the oral transdermal patch, we changed it to a fentanyl infusion, and that was started along with the supportive care. With that, the pain subsided, and then the end of life care was instituted, and this was explained to his relatives, and the patient expired free of pain 2 weeks. But the question we need to ask is, have we been too drug-centered or intervention-centered in our approach? Have we reviewed the role of non-pharmacological? Now, if you look at this particular patient, he was a highly educated retired doctor. So he knew everything about his disease. He had no financial concerns because all the cost of treatment was fully reimbursed. He had a very supportive family, a wife and a daughter, and his wife was a main caregiver and had taken the role of head of the family, managing all the affairs of the family, including the medical, the financial, etc. So could this gentleman have had psychosocial concerns? Possibly. He was very depressed because he knew that there was no cure for his disease and that he would not live long. So he had a sense of hopelessness, helplessness, and powerlessness as well. Despite being a doctor, he could not do anything to help. There were psychosocial problems because he was experiencing loneliness and isolation, because they had withdrawn from friends and relatives for 2 weeks, and only the treating physicians and the palliative care doctors were in touch with him. He had a low self-esteem. He had a CA rectum, and he had a lot of issues. In between, he used to have bleeding, and he even had a fissure. He had a ischiorectal abscess. So his wife had to do everything, and he was even his own activities like cleaning him and putting on the diaper, everything was being done. So he had a very low self-esteem. He also had a lot of guilt, possibly, because his family had given up all their routine activities. The wife had given up a job so that she could be his full-time caregiver. So there was a sense of guilt also. And there was a role reversal because he was the head of the family, but his now wife had taken over all his responsibilities. He was unable to carry on his normal responsibilities of a primary a breadwinner of the family or taking care of the finances. Everything had to be done. So there was what is called a role reversal. So again, if you look at this slide, you can see that this is a WHO analgesic ladder, step 1, step 2, step 3. At every step, we have to address the psychosocial issues. And then you go into the interventional approach where you can give various nerve blocks. And of course, there are also advanced interventional approach where it's basically central neurodestructive procedures where the risks are more than the benefits. So this is generally not done. Now, if everything fails, then, and the patient is a terminal case, we may have to resort to palliative sedation. We can accept failure in our managing pain, but we should never desert the patient. We should be fellow travelers in their difficult journey. We should convey our failure to treat his pain, but convey it with sensitivity. And they won't feel so bad after that, nor will the caregivers also feel bad. But we have to continue the psychosocial spiritual support till the end. And any worsening of the condition or any intermittent issues should be dealt with. That's it.
Thank you, Dr. Mary Abraham, for that wonderful presentation. Now the platform is open to participants for questions. I see one hand raised already. Dr. Anish, over to you.
Yeah, good evening. So I'm working in ICU and I've been seeing a lot of patients. So recently there was a patient with severe breathing difficulty like post-COVID, and the patient was suffering a lot. So we were giving him a bolus of fentanyl. And later we had a discussion about using a fentanyl patch, which is available in our setting. So I want to know, is there any restriction in using a fentanyl patch for difficult pain management?
But did this gentleman have pain also?
He was in severe respiratory distress.
Yeah, but did he have pain? Oh, you are only talking of sedation, is it?
Yes, for sedation. And if you think about it, it is like kind of a palliative case because he was a post-COVID with severe lung fibrosis.
Okay.
So he was like very much in distress. He was on NIV, and to reduce the distress, we were thinking of using a fentanyl patch, and there was a suggestion that there is some restriction in using fentanyl patch for such patients, and it can be used only in severe pain.
See,
I just want to know whether it is
action of fentanyl patch. It doesn't come on immediately, right? You have
yes.
at least 12 to 24 hours before its effect can come on. You know, the peak effect can come on. So at least for the next 12 hours, you will not have any effect. But I think there are better options for providing palliative sedation. One option would be clonazepam. It has been used for terminal sedation. Okay, rather than using when the patient doesn't have pain, then instead of a patch, either you have to give him intravenous as a subcutaneous as intravenous infusion, or you can use other sedatives like benzodiazepines. And one particular benzodiazepine we can use is clonazepam. You can start with 0.5 mg, either orally or intramuscularly or intravenously, and you can increase it up to 8 mg. So that would be a better option to provide palliative sedation as compared to fentanyl. And certainly not a patch, because patch is something which will take time for it to act.
Yes.
And
The thing is that the patient was already on clonazepam, and
Okay,
we
he
were
was
giving him IV fentanyl infusion
uh,
and on top boluses.
okay.
When it was not sufficient, we were giving fentanyl at 5 ml per hour,
Uh,
5 mics per hour, plus we were giving in between bolus of like 10 or 20. And we were planning to shift him out of the ICU to a room where the infusion pump is not manageable.
okay.
So that's why we were considering putting a patch and shifting him out in like later next day or something like that.
I, I
So
I don't know whether a patch would be the best option in him,
hmm,
because if he's
okay,
already getting IV fentanyl infusion, that is, it's more potent than giving a patch. So patch may
yeah,
not
yeah.
a little
Thing is that
erratic.
we want to shift him to the room and giving IV fentanyl in a room. I don't know, in a normal hospital setting, they may not accept, and sudden saturation fall and things like that may not be manageable. There
Okay.
is not even a monitor in the room, so that's why we were thinking of such an option. And somebody told that one of the anesthetists told that there is some legal issue in using fentanyl patch. So I just wanted to clear that whether is there any legal issues in using a fentanyl patch.
No legal issues except that it has to be got through a prescription. Patches and all,
Yeah.
you have to use a special form to prescribe it because it comes under the
Yes,
indication.
yes, yes.
Other than that, there are no other issues using a fentanyl patch. But
Oh,
I'm not sure whether this gentleman will settle down with the fentanyl. That's all.
and another one more doubt. We have post-op care where we are routinely using buprenorphine patch.
Ah,
So, as discussed earlier, buprenorphine also, I think it will take some time for the pain relief to appear.
yeah, yeah. But then
Yeah,
in the post-op patient, they will also be having the residual effects of the drugs that were given. And then
yes,
when you start a buprenorphine patch, it will take over, because there's always a residual effect of all the analgesics and the that we have given during anesthesia. So you can use buprenorphine patch. I've not used it in my practice as an anesthetist, buprenorphine patch,
okay.
but I use it more for chronic pain. But I don't know about post-operative pain. We have other options, so we don't use buprenorphine.
Okay, okay. Thank you.
Thank you, Dr. Anish. Moving on, Dr. Neelam had commented that we use midazolam infusion for sedation in ICU. I believe that was in continuation with Dr. Anish's query.
Yeah. So
Um,
that is also a drug that can be given, like clonazepam, even midazolam can be given. But clonazepam particularly is effective, and there's a neuropathic pain element also, because that is the only benzodiazepine that can be given for neuropathic pain. Clonazepam.
Dr. Benedicta wants to know, for patients who are being managed at home, what are options for end of life pain management or terminal sedation? That is when IV or infusions are not available in such situations.
Can I can you repeat the question, please?
For patients who are being managed at home, what are options for end of life pain management or terminal sedation when IV or infusions are not available?
Okay. So in such cases, you can use a patch also, fentanyl patches. See, orally, they may not be in a position to take it. So you can give either a fentanyl lollipop. I don't know if that's available, the oral transmucosal fentanyl citrate lollipops, or you can use a transdermal patch there, such patients. Because an IV and subcutaneous is not effective and the patient has pain, but is the patient taking orally? Is the patient taking orally?
Dr. Benedicta, would you please unmute and
Is the patient able to take orally?
Dr. Benedicta, do we have your attention, please? I think she might be facing some technical glitches. So till the time she responds back, Dr. Arnab has shared his experience that I think what happened in COVID ICU was that we sedated a patient as soon as they were restless in any way. There was no scope for non-pharmacological management. This was his experience in COVID ICU.
Uh, Hi, Arnav here. Uh, I just put this point because when ma'am was mentioning that non-pharmacological interventions should be done in every step of pain, but my experience has been that when they are in the initial stages of pain, they are actually refuse to go to a counselor or a psychiatrist or even just a social worker to discuss their psychosocial issues. So how can we uh, kind of convince patients to also consider this option along with pharmacological treatment?
Now, psychosocial counseling doesn't always mean going to a psychologist or a psychiatrist. The treating doctor themselves can do the psychosocial counseling many a time. Believe me, because they have so much confidence in the treating physician that you can talk, you can delve into their history, psychosocial history, and a lot of issues you can yourself try to address, because the person that they are fully confident, and if you have established a good rapport with the patient, they will automatically confide all their problems in you. I'm talking out of my own personal experience. And many a time they do not want to go to psychologists, and it is you who could be the best. I call it amateur psychologist. That although we do not have training in it, but by virtue of being a humane doctor, you can yourself be take care of a lot of their psychosocial concerns. It doesn't always mean that they need to take medicines or they need to go to a counseling center. Obviously, they at that point of time, they feel that's the last thing that they want to do, because they are suffering because of pain and because of cancer. If they are agreeable to it, it's fine, because many good cancer centers have got the attending psychologists also, so they know how to talk to them. And I know that some of them are very good, but the confidence they get in their own treating physician is something which is also very, very important. And you don't have to be a professional psychologist to do psychosocial.
So, ma'am, is there any training that you can recommend to us that we can train ourselves to be and to do counseling or cognitive behavioral therapy, maybe in the initial phases until they are ready to meet somebody else to disclose all their personal details?
Yeah. See, there are a lot of therapies, that are available for counseling, like cognitive behavior therapy, acceptance commitment therapy. Then these things are all done by the psychologist. Okay. Now, I was also interested to know about it, to learn more about it, but I found that it is very difficult to do these things. So, but like I said, those are the therapies that a psychologist can do. But like I said, uh, by just establishing a rapport and listening to the patient itself can be very good psychological therapy. The therapies like CBT and all that thing, ACT and all, are something that maybe we will not be able to do it. But we will be doing it in a very different way when we talk to the patient. But I personally don't know where you can learn it. I tried looking it up for myself, but I did not meet with good success.
Thank
But
you. Thank you, ma'am.
there may be, there are courses there, but they're all long drawn out and I don't have the time to go for that. So I think the best possible thing is just active listening to your patient itself can be one of the best psychotherapies. You have to listen to their pain, listen to their the way they talk, and they just vent out all their feelings, and that itself can be a venting is also a form of therapy. You see, the venting that they do by talking and releasing all their problems itself is a kind of a therapy. And then you always tell them that give them positive thoughts and positive ideas. And so these are all ways in which you can do it if they are not willing to go for a psychiatrist.
Thank you, Dr. Mary. Dr. Benedicta, do we have you back? I think she's still facing some difficulties. Dr. Newstar, over to you.
Uh, yes, good evening, ma'am. Am I audible?
Yes.
Yeah, actually, ma'am, I have noted down a few questions that I have from the lecture that you have given. Like when you're talking about conversion in after converting the equi-analgesic dose, you said that we need to reduce the dose. So I just wanted to know, ma'am, actually, after calculating the equi-analgesic dose, after coming up with that, do you start with that dose and then see for effective treatment, and then you come down to 50%, 20%, or even before you
So
start
before
giving
you
to the
start the
patient?
dose, except for methadone,
Before.
because for
Okay.
methadone, what the conversion is very conservative. So since it has no cross tolerance at all, it can be given like that. But other drugs, we need to reduce it and then start. Okay. So if the patient has well-controlled pain, you reduce it by 50%, but poorly controlled pain, you reduce it by 25%, and then you start on that dose. But don't start it after conversion.
Oh, okay, ma'am. Thank you. Ma'am, regarding some of the methods like you mentioned about usage of continuous pumps, so like what are the like routes that you're giving, ma'am? Is it continuous subcutaneous or
You can give
continuous
continuous subcutaneous, you can give continuous
intravenous,
intravenous,
intrathecal?
continuous epidural, okay? And of course, there's continuous intrathecal as well, because intrathecal pumps are there where you can give morphine
Okay.
intrathecally. Of course, that's very advanced and not available for most people. But things like epidural and nerve blocks, you want to give a brachial plexus nerve, you can just put a catheter there and attach a pump there, and you can give a continuous brachial plexus block. Okay, or a sciatic block or a femoral nerve block. So nerve blocks can be given continuously, but along with that, you can also give epidural continuously and also intravenous or subcutaneous.
Okay, thank you, ma'am. And one more last question, ma'am. Actually, when you talked about difficult pain management, you mentioned something about palliative sedations. Is that synonymous with terminal sedation, ma'am, or?
It is synonymous.
Okay, right. Yeah, thank you, ma'am.
Thank you, Dr. Mary. Dr. Anisha has suggested that opinion that just sitting and listening to the patient and relatives itself is very effective in communication. And we have a couple of hands raised. Dr. Nari, over to you first.
Yes, ma'am. I was wondering, ma'am, if we are going to use those elastomeric pumps and we're giving it through the IV route, should the dilution be done by us at the hospital and load it into the pump and give it to the patient? Or can we
Definitely.
give the actual vials to the patient and ask them?
No.
No.
It
Okay.
has to be loaded by either the doctor or by a trained nurse. So in many hospitals, the nurses also are now able to load the CADD pump. I showed you, the picture of the CADD or the elastomeric pump. It can be done by nurses. They explain in a very aseptic way you have to do it. It should not be given to the patient to do it. Never. Okay.
Okay. Because sometimes they come from other states and it's a long way to travel. So if they have at their hospital, suppose they don't have injectable morphine or something, but they have nurses who can do the dilution, in those kind of situations, I was wondering.
Yeah, the nurses can do it. But they have to be explained how to do it, how to do it.
Okay.
But it should not be given to the patient.
Okay. Okay. Thank you.
Dr. Arnav?
Hello, am I audible?
Yeah.
Yes.
Okay. So I wanted to ask ma'am about her experience on dry needling, because I have never understood, like, does it actually help? Because I have not heard of any patient so far who has like who was even prescribed dry needling. We have discussed it in theory, but I wanted to ask ma'am's experience about it.
Okay. So, see, a lot of pain can be due to, like, for example, today the case discussion that we're doing on post-mastectomy syndrome, I think that could be a case in which we could use dry needling. So basically, dry needling is done when there is, a pain can be due to a neuropathic component, it could be due to a myofascial component. A lot of pain can be due to just spasm and rigidity of the muscles. Particularly after mastectomy, I have seen patients with such stiff pectoralis major, and all the muscles of the shoulder and the upper arm and the upper chest are all very, very tight, and that itself can cause a lot of pain. And that could lead to what is called the post-mastectomy pain syndrome. So if you find that these are the muscles that are contributing to the pain, then by doing dry needling of the muscles, you will be able to relieve a lot of pain. I've seen it myself, and although I do it a lot for chronic pain conditions, not cancer pain, but in selected cancer pain patients where you feel there's a lot of muscle spasm, you can use dry needling. Again, with a word of caution that this has to be done only after taking proper training. Particularly when you want to give on the chest wall, then you have to do what is called an ultrasound guided dry needling, so that you're not likely to cause injury to the underlying pleura. But for the extremities and the back, the legs, and you can do it even without ultrasound. But when you go to certain areas, then it is always preferable to do. For example, you want to do dry needling of the neck. Okay, you have a very stiff sternocleidomastoid and or scalene muscles, then in that case, you need to do an ultrasound guided dry needling. But for the back pains and for the limb pains, you can do even without ultrasound. But it is very, very potent tool for the relief of pain. And I'm regularly doing it for treating my chronic. Not
Okay,
many people
thank you.
do it.
Thank you so
Not
much.
many people do it, but there are, it's getting a little more awareness, and now more and more people are doing it. Now, remember, physiotherapists also do dry needling, but their dry needling is very different from what we physicians do. Okay, they insert just few needles, maybe one here and one there, then they remove it immediately. Sometimes they peck at it or twirl it, but we don't do anything of that. We needle the particular muscle. If it is levator scapulae, we do that. If it's trapezius, we do that, or supraspinatus. We needle muscles based on the anatomy. And we keep the needles there for half an hour without any manipulation. At the end of half an hour, you remove it. And this is not, there are proofs that dry needling can cause pain, because there are various studies showing ultrasound that before needling and after needling, when you do the ultrasound, you find that the fibrillation that's happening in the muscles has actually become quiescent once the needle is there for half an hour. And further, even in the West, people are doing studies on dry needling where they have actually done microdialysis of the particular muscle and found that the less inflammatory mediators after dry needling as compared to this. So there is scientific proof that dry needling is also, besides the mechanical effect of releasing a muscle once the needle is inside. Want to know more about it? I can tell you where you can get your training and things like that.
Thank you, ma'am. Thank you so much. Now, I think Dr. Smita has raised her hand. Dr. Smita?
Shri Priya, now it's 6:10, I think,
Yeah.
6:05. Very soon we'll have to go in for a case discussion. So
Yes.
we'll take this question now. What's the question, please?
Good morning. Good evening, Doctor. Mary, I just wanted to ask you, how do you manage refilling the syringe pumps when you send them home with the elastomeric pumps or with the CAD pumps? attendant would be, it's obviously not practical to get the patient back to the hospital every time it needs to be refilled. What about, I mean, is there any way to work around it? Definitely the drug has to be diluted, but how do we manage it?
It has to be done by people who know how to use it. Okay.
Yes,
Not that
yes.
everyone knows how to use a cat pump. Now, elastomeric pumps also, training has to be needed for that particular nurse to do it.
Yeah.
Sometimes if the pump is there for a week, you have to ask them to come back after. It's not that they can do it anywhere, because it is always, when you're doing these things, you should not cause any overdosing or side effects due to the thing, because after all, you're giving it either intravenously or through the nerve block. So you have to be extra cautious. Plus, whenever you use these catheters, it's always important to inspect the site.
Right, okay.
I just asking the patient to come back. The infection is one probable, complication that can happen. So it's always good to get the patient back, inspect the site to see whether the site is clean and whether there's a need of antibiotic, and also it has a dual purpose. So you have to also monitor for that. If it's lying there and the patient is going on doing, we don't know whether there is some infection also happening along with it, right? So.
We use it in a post-op setting, but in a home setting, it's I'm just imagining it.
They can change the dressing of the pump, but for filling it, I think they'll have to. It's always good to come back and see the place, see the site of it.
Okay, thank you.
Thank you. I do see a couple of more questions and hands raised, but in the best interest of time, Dr. Mary, with your permission, shall we move on to the case presentation first? Then we will come back to the.
Can come back up.
Thank you so much. Dr. Aisha?
Yes, thank you. Good evening, everybody. Dr. Mary, Madam, what all questions I had to raise with this case, you had it actually in one slide. So I'm very grateful for your presentation. So I'm Dr. Aisha Jalil. I'm a radiation oncologist. I'm working in Cochin. So I'm presenting the clinical details of a 42-year-old male. Carpenter by profession. So he came to us in August 2021 with complaints of left chest wall swelling of about 1 year duration, ulceration and bleeding of 2 months, and associated with pain, 2 months duration. The history is like this. He presented with a lump on the left chest wall. He notices chest wall swelling almost 1.5 years back. And also there was swelling in the armpit, which gradually progressed in size. He was evaluated at a local hospital, found to have a left chest wall swelling and axillary lymph nodes, and he was advised surgery. But somehow he didn't go for surgery and he didn't take any treatment. He had a delay in treatment for almost a year. And then he presented to us last August. By that time, that mass had ulcerated and it had started, there was minimal bleeding. He also had complaints of restricted movement of the left shoulder. Next slide, please. So on examination, he was conscious oriented with all the vital signs were stable. And on local examination, there was a 9 × 9 centimeter mass in the left chest wall, which was hard and fixed, not mobile, with hard matted left axillary lymph node of about 8 × 5 centimeters in size. There was an ulcer over the swelling of 4 × 3 centimeter size. And there was left shoulder abduction movement restriction to about 45 degrees. Next slide, please. So the investigations were that he was evaluated with a biopsy first, which revealed invasive carcinoma of breast. He was evaluated further with a PET-CT scan to know the stage of the disease, which showed mass in the left breast with infiltration of the chest wall muscles and left retropectoral region with multiple axillary and mediastinal lymph nodes, bilateral lung metastasis. There was also a small lytic lesion in the D2 spinous process. In view of metastatic disease, he was started on endocrine therapy with tamoxifen and ribociclib, which is recommended in a metastatic setting of 600 milligram OD. By starting and at that point of time, with pain was controlled with Ultrasec, which was given twice daily. And he had an immediate response, like the ulcer and the swelling had a very good response. And he was continued on systemic treatment. Next slide, please. Next slide, please. So he came to our department last month when after an initial response, his swelling again started progressing, and that ulcer, he developed an ulcer bleeding. So he was referred to us for palliative radiation, the ulcer, bleeding ulcer. Regarding the psychosocial aspect, he was a carpenter. He lives in his own house. His father passed away. He lives with a 65-year-old mother who is actually the breadwinner. She goes to a factory. His younger brother committed suicide 2 years back. He's unmarried, and his cousins help him financially. As of now, he's not working. He's undergoing an expensive treatment, and he has stopped going to temple. He feels that he feels disconnected spiritually, and he feels lonely. He even asked one of the consultants that whether he can marry now because he feels lonely, and he regrets that he didn't get married or didn't think of starting a family at the right time. So medications are, as of now, he's on tamoxifen 20 milligrams, and right now he's not complaining of any pain, and he's off pain medication. Next slide, please. So the concerns are, one, physically, he has a metastatic disease with chest wall infiltration, and he has a shoulder movement restriction, which is not allowing him to go to work. Psychosocially, psychosocial support for the mother, and he himself feels very lonely. Financially, he feels that he had some money after he had, which was spent for his expensive treatment, and he feels very sad about it. He's not able to work. He feels guilty that right now he has to depend on his mother and his cousins, and spiritually also he feels detached. Next slide, please. So summarizing, he is a 42-year-old unmarried man who lives with his elderly mother, diagnosed with metastatic breast cancer with chest wall infiltration, ulcer and bleeding, and restriction of shoulder movement. So the discussion points I wanted to raise were, one, physically, the point in continuing systemic treatment, especially when it is expensive. Secondly, how do you manage the wound? Will physiotherapy help for the shoulder movement? He has shoulder movement restriction because of the chest wall infiltration. So will any kind of physiotherapy help him? And then it's the social support for the patient and the mother, and the financial aid. And can he resume work, or can he be rehabilitated to do any job with his shoulder issue? And how can we address his feeling of being detached? Thank you.
Thank you, Dr. Aisha, for bringing in that wonderful case. Now the forum is open to the participants for their opinions before we move on to the faculty's final words.
So anybody here would like to take anything further or any doubts regarding the presentation?
Dr. Anish?
Yes, so regarding this patient, I think we can, just like we discussed, we can obviously suggest physiotherapy, dry needling, or even local infiltration to reduce his pain. And if the physiotherapy is somewhat effective, he'll be able to go for some kind of even not so hard labor, but some kind of labor, and it will be a better comfort for him. And I think he also should be uh, enrolled to the support groups, where in some way he can get financial support also from
Sorry to disturb, Dr. Anish, but I think we are losing your
central
signal. Dr. Anish.
government aid or something like that. And physiotherapy is a good way of rehabilitation, and even other modalities of medicine. Yes. Yeah, can you hear me now?
Yes, but I think not sure if
Sorry,
everyone knows
the
you.
network
You can
issue.
switch
Can you
off
hear
your
me?
video for some time and continue.
Hello, can you hear me now?
Yes, please continue.
I just switched off the video, and so I think physiotherapy will be of great help. I also think that there are other modalities of medicine like Ayurveda, allopathy can also help with this pain, and local infiltration and all. I think personally, I think that the increasing of pain meds for him will not be a good idea, because he wants to go for work, can make him drowsy. And we will have to enroll him in support groups and government supports for financial aid and things like that. Thank you.
Aisha, I just had a question. What is the level of pain
Yes,
at the
ma'am.
moment that
Yes,
the
ma'am.
Aisha, can you tell me how much pain the patient has?
Right. And right now he's comfortable. He's not complaining of any pain right now. He has
So he,
undergone radiotherapy. He has completed radiation. He is off any pain medication right now. He's not complaining of any pain.
okay. So pain is not an issue, but physical point of view, like,
No.
and whenever we discuss any case, we have to look at it from a total pain management, right? So there is physical, psychological,
Yes.
social, spiritual. Now, physically, he has
Okay.
pain is not a major concern at the moment, but he has got a disability,
No.
the restriction of the shoulder, right? So we need to allow him to, because his abduction is restricted because of the chest wall infiltration. So we need to examine him and see where exactly is the problem. What are the movements that are restricted? What are the muscles that are involved? Okay. Is it flexion, extension, abduction, internal rotation, external rotation? So do a thorough examination of the shoulder to see which are the muscles. It could be the latissimus dorsi, it could be the serratus, it could be anything. Okay, so we need to first assess that pectoralis. It's a very important thing that can cause restriction of various movements of the shoulder. So we need to see that. And that is the main problem physically that he has. But the other things that he has are, he has a lot of psychological issues. He's lonely, like someone suggested, maybe put him on a support group. Maybe he would need a company of other people, that will help him. And very important is if you can get him back to work, because resuming his occupation itself will do good for him if he is able to do it. I mean, other physical issues, wound management, right? There's an open wound, no, Aisha? Okay, so that wound management
There's an
also,
open one. Yes.
so that is also a thing that has to be addressed from the physical point of view. And then we need to address this psychological problems regarding loneliness, the feeling of, that not able to earn his living, and the financial concerns that he has, because for that he will feel better if he goes to work. And of course, he has got spiritual issues also. He must be questioning God, and he stopped going to the temple and things like that, which shows that he has got spiritual issues. So basically, someone needs to counsel him on all these and try to provide as much psychosocial support as possible. Because besides addressing the physical things, unless you address all the other issues, you will never have a person who is totally, who's satisfied, right? So, like I mentioned, for the Physiotherapy can help, but again, it has, when there is restriction of movement, physiotherapy definitely will help. But like I said, in this particular patient, if you see which are the muscles that are involved and do dry needling for the muscles, that will make a major difference. Or you can even add an anti-spasmodic, like baclofen can be added in a small dose, start off with 5 mg BD to reduce some of the spasticity. Okay. And yeah, anything else? Anybody else would like to add anything to this? Occupation, getting him back to work would be a very major improvement. It will first of all make him feel that he's useful in society. It will also help in taking care of his daily financial needs. And of course, if someone who would, since he's having a lot of loneliness, if you can get people who can visit him or some support group, that will also be helpful.
Hello.
Yes.
Yes. Thank you very much, ma'am, for the presentation. It's really very much educative. So for this case, like you rightly said, ma'am, this patient needs a lot of psychosocial support, not only for him, but for the mother and the cousin as well. They all need a lot of psychosocial support, because how long will the mother hold on supporting him? How long will the nephew or sister hold on to support him? Would be a very big problem. And for his age, he's still not married, no child, so it can be really very much distressing, even more than the physical problems that he's having. So I think joining him to a support group, maybe he will get one woman he will get married to that has the same problem. Thank you very much.
Yeah, very important, Gregory. Particularly, caregivers also need to be given support because they are going through a lot of strain. So the caregivers of cancer patients, by just speaking to them and understanding the problems they're going through, they also need to vent their feelings. They are very tired physically, emotionally, very, very tired people, the caregivers. So you are right. Caregiver support is also very, very.
Ma'am, we have few comments in the chat. Dr. Jyoti is of the opinion that along with palliative radiotherapy, we should also consider giving her chemotherapy, because if the bulk of the tumor decreases, then she might have better shoulder function as well, because only hormonal therapy and targeted therapy have been used so far. What would be your thoughts on that, ma'am?
I think I'm not the person to give answer for that. This will be the oncologist has to take a call on that. But definitely, tumor debulking can also be important by whatever means it can. It will benefit him in reducing his physical problems.
Madam, I would like to raise one thing. The main dilemma we oncologists and the patients go through is the finances of the treatment. How far it will be beneficial, and what is the point in spending this amount? This is a question and that always comes up. When you have a disease, when you have a young patient, when you have a proven thing that there will be a certain quality of life to the patient if you start on certain treatment, but when the treatment is expensive, it's actually a very big problem for the patients, the caregivers, as well as the treating physician as well. This is something that we grow through. When you have advances in science, when a lot of medicines are coming up, but all of them are very, very expensive. It is it's a big dilemma that we and the patients go through. Face.
The only thing is all the WHO analgesic ladder drugs are not expensive.
Yeah, yes, thankfully.
I believe a day's morphine will cost some 4 rupees, and fentanyl, methadone costs all less than 10 rupees, So it's very, very inexpensive.
Yes.
These drugs.
Yes.
But of course, chemotherapy, radiotherapy and all, unless you go to a government hospital, but then in government hospital, there's a lot of red tapeism there and waiting there. Facilities
Yes.
are there, but to reach the patient is very difficult.
Yes.
Thank you, ma'am. So as we have a few more minutes as we await for people to raise their hands. Meanwhile, just going back to certain intrigue on needling, certain questions which were asked earlier regarding dry needling. So one of the questions is, how does dry needling work? How does it break the muscle spasm? That is one. And there are people who are showing interest in where they can get trained for dry needling. And one personal question from my end is, how far, how many hours do you have to repeat it? Like, how often do you have to repeat the procedure? How long does the effect last? If you could give us some insight on that, ma'am.
Dry Needling Act. Now, a lot of problem, like particularly in this particular patient, is there is the restriction of movement is because there's a muscle shortening. Okay, and muscle shortening is happening is because the actin and myosin that have gone together are not coming back into the relaxed position. Okay, the total muscle relaxation is not happening. It is remaining contracted, and that contracted muscle over time gets shortened so that it is not able to contract. And dry needling, by its physical presence in the muscle, can actually cause a relaxation of the muscle, which the physiotherapists are trying to do by doing their stretching. But the stretching can be painful and it takes longer, but dry needling is a more potent way of relaxing that muscle. But besides that, dry needling, it creates micro trauma inside the muscle, and that releases various factors like nerve growth factors and things like that. A lot of neurotransmitters are released inside the muscle, which can cause healing of that thing. And of course, it has been shown on the ultrasound that the tightened muscle is, the muscle loses its, the structural myofibril pattern is lost when the muscles are in shortened or tightened, and that gradually comes down and settles down. It has been shown on the ultrasound. So basically, it is the physical presence and also the chemicals that are released after the thing. And particularly when there are knots in the muscle, like you have in the trapezius, you have a knot is formed, which can be very tender. Needling can actually release all the inflammatory substances that are mediators that are trapped inside the knot, and it improves circulation into the corrugate. So there are various mechanisms by which dry needling. The question is training for dry needling. As of now, I can only think of a place in Bombay where it is being done, where I myself got trained in that, and that is Ashirvad Pain Management Center. So if you look up in the net on Ashirvad, you will find a lot of things. And they have also brought a number of papers, research papers. It's a research institute, and they brought out research papers on dry needling for a variety of conditions, including cancer. Okay, so you have to look that up. Ashirvad Pain Institute in Mumbai. That's the only place I know where training is being given at the moment. It's training people and they're going out, but whether they have started training, I don't know. The other thing is these sessions may have to be repeated maybe twice a week only. Like you do a session today, you can repeat it after 2-3 days. So only twice a week session. Each time the needles are left in place for half an hour. And the patient can just walk out. It's an OPD procedure.
Thank you, ma'am. We don't have any more questions from the participants, and we have reached the last minute of the session. If you would like to give some closing remarks, ma'am.
So what I was trying to say is that difficult pain is indeed difficult to treat. And you have exhausted the WHO ladder, you're looking for other options. So then we have to look at whether like I said, review the patient, review everything, whether there's disease progression, whether there is a failed route of absorption, as in this particular patient that we saw, that there was disease progression, there was a failed route, so we had to convert the route. Then we had to also take care of his psychosocial concerns, which everyone has, So it is, we have got some options, but more than anything, it is the empathy that the doctor can show the patient, which can actually have a very good psychosocial. Like you don't have to be a trained counselor, but you can, by just listening to the patient and showing empathy, they themselves will open up, and that itself can be a very good psychological therapy. That is what I have seen in my experience. And they will come out with all the details that they would normally not tell anyone. Whereas if you see a patient and you know there's time constraint, in 15 minutes you have to see a patient and you just start asking straight away everything, they won't feel like opening up. It's only when you start listening to them that they will open up, right? So patients have their own dignity also. We have to respect that. That's all I have to say.
Thank you so much, Dr. Mary. We do know that this is a vast topic by itself. Difficult pain is a very vast topic by itself. And in case you are having any further queries, our WhatsApp group is open for that. And also in the PPT, you'll be receiving Mary ma'am's mail ID as well. So please don't hesitate to get in touch with her. This I'm saying without getting her prior consent, but I do know that she will always be there to answer our queries. Thank you so much, Dr. Mary, for joining us from your busy schedule. We do understand that you are a busy person and still you could find out a good 1.5 hour time for this cohort. Thank you so much for that. And hope that this has been an enlightening session for everyone as usual. So with that note, this is Sri Priya along with Dr. Mary Abraham and Dr. Deepak Sudhakaran signing off from the Tips Eco Hub. See you in the next session with another interesting topic and an eminent faculty. Till then, everyone, stay safe, be happy. Take care. Bye-bye.